Hello, good evening everyone, and welcome to the eUROGEN webinar series. Just before we get started, I'd like to take a couple of minutes to explain a little bit about what eUROGEN is and does. eUROGEN is one of the 24 European reference networks created by the European Commission in 2017. And the networks all deal with patients with rare diseases and complex conditions, so where the expertise is rare. And in eUROGEN, we're currently a network of 56 hospitals in 20 member states. And our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis and healthcare across the EU. So some of our activities, I hope you noticed at the beginning with the slides, we do virtual cross-border consultations, and this is free to any healthcare professional working in the EU. So we can access a secure system called the Clinical Patient Management System and provide advice across borders. We also collaborate on the education and training activities like this webinar programme. We produce clinical guidelines, and also we have a patient registry which we're developing. One of the things we know is data on rare diseases is fragmented and scattered across Europe, so the registries aim to bring all of that together. And we have also just collaborated on the textbook, Rare and Complex Urology, so please do look that one up. It's published by Elsevier. So tonight's webinar is about survivorship in penile cancer, which of course is one of the rare diseases that we cover in our network. And tonight we have Dr. Ben Ayres, who's a urologist at St George's Hospital in London, and he's got a special interest in andrology, bladder cancer, prostate cancer and penile cancer. So we also, one of the great things about the reference network is we work with patient representatives. So tonight we have members of our group, our ePAG group as we call it. So we have Rob Corns and John Osborne. John Osborne is a survivor and he's also chair of our ePAG group, and Rob is a male specialist nurse, and he is also affiliated with the Orchid male cancer charity. So thank you very much to both of you. We really appreciate everyone being here this evening and sharing your expertise with us. So the webinar will discuss the medical aspects and the patient journey when dealing with penile cancer, and it's accredited if you fill in the form after the webinar. So thank you very much. And Ben, I'm going to give you the floor. I understand we don't have camera, but we do have everything else working. Thank you, Ben. Over to you.
Brilliant. Well, apologies to those that are watching this that I'm not able to share my camera for some technical reason this evening, so apologies about that. But I'd like to thank eUROGEN for giving us the opportunity to talk about survivorship in penile cancer, and we're doing this presentation this evening on behalf of our colleagues in Workstream 3. So I have a few conflicts of interest to disclose relevant to penile cancer. I am on the EAU and ASCO penile cancer guidelines panel. I'm a trustee of the Orchid male cancer charity in the UK, which looks after male cancer, so does support men with penile cancer. I've been chairing the UK for the research subgroup for penile cancer, and I'm participating in a couple of penile cancer trials. I also have received speaker fees and for bladder cancer for bladder cancer and trial participation for bladder cancer. So survivorship. When we came to update the EAU guidelines on penile cancer, which were released last year, which we worked with the Americans on, we felt it was really important to talk about quality of life early on in the document. So we've got this statement here that's highlighted in yellow right at the start of the document, talking about really the importance of quality of life and survivorship in penile cancer. And why why is this? Why did we feel it was so important? And with all cancers, our patients go through the stress and anxiety of a cancer diagnosis, but there's more. Clearly, given the area of the body that's affected, there's a lot more psychological, potential psychological impact of this disease. And these are just a few comments from some patients. Now, some of these will ring true across all cancer types, but patient didn't know how to tell their family that they had penile cancer. Another showing frustration that the doctors treating him didn't know that penile cancer exists, so comes at his cancer diagnosis just not just with the anxiety and the fear of being diagnosed with cancer, but also some anger about the pathway that he has followed. Another one around the daily burden, the lymphedema, which again is a big survivorship element. Here one around the delay, waiting for the results of surveillance scans. Now this rings true across all cancers, but we know when people are waiting for scans and waiting for scans results, that brings their anxiety back up again. Piece there around the masculinity and the identity, and clearly having penile cancer makes you potentially question that. The urinary problems, and again the lack of knowledge and perhaps the stigma by being told to go to the STD clinic. And so there's a lot of stigma and taboo around penile cancer as well. And so when a patient is diagnosed with cancer and penile cancer, they do go on a psychological journey. So when they present with the symptoms, there may be this delay, which may come from the patient. They may not realize, there's lack of awareness of penile cancer. So there may be a delay in them seeing the doctor. The doctor, as we've heard from some of those testimonials, they may not realize what's going on, may misdiagnose, and so that can lead to some anger at the start. There's fear, there's embarrassment, there's pain. And then when the diagnosis is made, a lot of patients really start to have that fear and fear for their own mortality. And at that point, their focus is often on survival rather than necessarily the consequences of treatment. So it's important at this stage that as doctors, we do talk them through the consequences of treatment, but we do need to be aware that they may not be taking everything on board, and that they may not, they may need further discussions down the line about the consequences. And this is why at this stage, giving information, written information that the patient can reread and look at is really important. And if they have support, peer support or partner support, then clearly involving them is really important at this stage. And then after the treatment, and as we start to get into survivorship, there comes that struggle with the change that has occurred. So there's the struggle with the change to urinary function, to sexual function, the impact of lymphedema on day-to-day life, the impact of the surgery and the psychological impact of that on intimacy and relationships. Men may question their masculinity and their self-image. They may stop partaking in some of their social activities, so they may stop going to watch their local football team play or other sport team play, or may stop going to the pub for a drink because they're concerned particularly around voiding and using toilets. And depression can therefore quite quickly come in at this stage. And sometimes that depression can be a year, 18 months, 24 months down the line. So it's important that patients are aware that this process can take a long time, and that support is offered to them throughout. And then, over time, there will be that adjustment to the new normal, but this really only comes about through good communication, support, and counselling. So because of the impact on patients, there's a lot of unmet needs, psychological and emotional, unmet needs around relationships, and some around medical. So what can we as clinicians do to support our patients? And clearly it's really important after I finish this presentation that we hear from my colleagues on the call as well, Rob and John, about what more they feel can be done to support patients. And this there's a very good systematic review, as you can see referenced there, that really starts to tackle this and looks at all these different areas. So these are all the needs that penile cancer patients have in the survivorship period. And a lot of these, as I say, are unmet, and they're unmet because either we don't have the right services set up to support the patients, or as clinicians, we don't know how to offer that support ourselves. And hopefully by the time we finish this webinar, you'll feel a bit more empowered and supported to help your patients. So some of the emotional needs there are around loss of masculinity, the shock and disbelief of what's happened and the diagnosis, depression, sadness, fear, anxiety, embarrassment. So the stigma and the embarrassment of the part of the body that is involved, again, really can impact on the important communication that needs to happen to help the patients adjust. The relationships needs, clearly there's the impact on, potential impact on relationship with partners. There's the impact on sexual function. There may be performance anxiety, concerns around satisfying their partner, concerns about how to tell their family, not only that they've got cancer, but the part of the body that's impacted. Clearly relationships therefore may become damaged or lost, and it may be very difficult for patients to make new relationships. And as I said, they may avoid meeting friends as a result, because sometimes they don't want to talk about what's happened to them and to share with their friends. And then when it comes to medical needs, often there's a lack of advice on how to cope with all these symptoms and psychological impact of the disease. There's the impact of lymphedema, as we've already discussed. A lot of patients say that there was a lack of information up front on what to expect after the surgery. They say that it wouldn't stop them having the surgery, because the surgery was important for them to get through cancer, but to have more information up front will have helped them start to prepare for life afterwards. Clearly the need to possibly sit down to urinate and the cleanliness of toilets and not being able to use a urinal or have difficulty using a urinal for a lot of men can be a big impact. There's a general lack of rehabilitation and supportive care out there, and again the missed or incorrect diagnosis can cause a lot of anger that can take a long time to pass. One of my patients has written a stage show and goes and acts out his experiences of being a man with penile cancer and the impact that the treatment has had. And this is a very strong and powerful photograph, I think, of part of that play, showing clearly the impact that having penile surgery can have on a patient. So as I said, the common challenges that we as clinicians and our patients face are these unmet needs. There's the lack of general awareness about this disease amongst the general public and some doctors. A lot of men have difficulty communicating their feelings. It's really important we don't forget partners. The partners need support as well. So whenever we put on patient support groups, we should also be offering that to partners. The amount of information given, we've already talked about, and often there's a fragmented pathway and lack of support from the medical team. So if we were really trying to look at how we could build services to support our patients and deliver on some of those areas that I've just talked about, what could we design? Well, clearly we need to be patient-centered. We should be multidisciplinary and all work to our strengths and have access to counsellors, psychological support, specialist nurses. We should give upfront information to patients on what to expect, both verbal and written. We should have prehabilitation and rehabilitation services. We should have access for lymphedema services for those that need it. We should have access to survivorship services, which must include counselling, psychological support, relationship and sex therapy. Now, one of the tools that we use in the UK a lot is this holistic needs assessment. It taught you use it as a tool to talk to patients about the aspects shown there on the screen. So physical aspects of how the disease is affecting them, emotional aspects, some of the practical impact of the disease on their day-to-day life, the financial impact of the disease and potential spiritual impact. And this allows a very holistic assessment of the patient rather than a very clinically based one, which unfortunately as clinicians can often be the case when the patient comes to clinic after the treatment and in their follow-up period. We assess for recurrence of the cancer, but actually if we use tools like this, we'll be able to open up wider and broader conversations that not only allow us to do that clinical assessment and the physical assessment, but a much wider one. Our specialist nurses are expert at this, and it allows the development of a personalized care plan and has been shown to be a really useful tool in supporting patients with cancer. So the psychology of survivorship is all around the patient asking, why me? And the impact that the cancer and its treatment has on their identity, their body image, their masculinity, whether it impacts on their intimacy or not, whether they start thinking about their mortality. And clearly, some patients with penile cancer unfortunately have more aggressive disease, and that will be a real, very real concern for them. And adjusting and getting used to that new normal. So how can we help our patients adjust? Now, clearly, psychologists and counsellors are trained to deliver this, but as clinicians that the patients interact with and often look for advice and guidance, what can we do to start them on that journey? Well, the first thing is to help them to adjust, is to help them look at what their goals and aspirations are, and often what they may have achieved already in their life and what their lived life experience is will help them adjust. So some people talk about the fact that they're already a grandfather and they've got their grandchildren, and they're inspired and will look and help and look after their grandchildren. That gives them something, and they've already have some lived experience. It helps them start to adjust perhaps easier than somebody who is maybe diagnosed with penile cancer much earlier in their life. Likewise, people that perhaps have the support of a partner may find it easier to start adjusting than someone who is trying to do this on their own and then has struggles to find new relationships because of the disease. Body and clearly body image is a really important part of how somebody can adjust. Their sort of self-esteem and how much it knocks their self-esteem, their confidence, and their social identities. So as I say, some people sort of start sitting back and stop interacting, stop going out because they're worried about the toilet or worried about having to talk about what they've been through. So again, trying to address that with the patients is important to try and help them see their self-worth. And then clearly some existential beliefs may help people to adjust. So what strategies can we suggest to patients? Clearly, we should be helping them think of strategies to be kind to themselves, to give them time and to make room for their emotions, and to sort of, say that these emotions are normal, to normalize what's going on for them. It's important they set targets for the future that will help them to move forward. Again, to adjust their expectations, to expect some uncertainty, and to use what has worked for them in the past and what they know works for them, try and get them to look back at previous times where they've had to cope and how they have coped, and get them to try and use those coping mechanisms again. And it's really important that they talk and perhaps connect with other people that have gone through this disease. And that's why having peer support and patient support groups are really important. How can we help them navigate intimacy? Well, clearly this is about how they're feeling about their body image and their masculinity comes together with potential relationships. And as I say, this is often different for people that are already in relationships and those that aren't. But those that are in relationships often worry about what the other person in that relationship is thinking and is concerned about. So again, communication is really key here. And again, sexual therapists and psychologists are really important. There are some quotes here that are taken from some psychological studies that have been published on penile cancer that are referenced below. But as you can see, these are what some patients have said following treatment for penile cancer. So our sex life was so good before. So how can sex mean anything now if we can't do it the same way? We are sort of just living our lives alongside each other without very much intimacy at all. So clearly that's where more communication and help from counsellors is needed. I just don't feel attractive. So clearly this is body image and feeling of masculinity. I just don't feel attractive anymore, and I don't see why she stays with me. So again, there's doubt in there, isn't there? They've lost their self-esteem. I think she only stays with me because she feels she has to now. So again, there's concern about what the other partner is thinking. So again, how can we help our patients talk about these issues? So I've been through what the issues are and some of the strategies, and I think they're broken down here. So I think the first thing is active discussion. We have to break the stigma, we have to break the taboo, and we have to give our patients permission to talk and to address these issues. And I think one of the ways that has been shown to be really helpful is to use patient-reported outcome measures, or PROMs. So by getting patients to fill in PROMs or questionnaires before they come to clinic about the potential areas that they might want to talk, it almost starts to unlock the door. It gives them that permission to start talking about these areas and get some thinking about them. They may not have thought about them, or they may have thought about them and thought, how am I going to raise that with my doctor? Well, this sort of using PROMs can break down some of the barriers. Equally, it can give the doctor a way in, because the doctor can look at the PROM and say, oh, I see that you've scored, voiding or your sexual function very poor. Let's talk about that. So I think active discussion and trying to break down that stigma taboo and encourage conversation is really important. The next important point is to be really holistic in your approach. So not just taking the consultation as a clinical one. So not just checking that has the cancer come back or not, although that clearly is important, but to really have a holistic approach and talk about all those other impacts and psychological, emotional and social that the disease can have. So be holistic in your approach. And as I say, a lot of doctors can feel a little uncomfortable about this. So it's important that your service is set up appropriately, so you've got the right people to refer on to if you need to, be that psychologists, sex therapists, or specialist nurses. And also, again, using tools like the holistic needs assessment can help with this. It's important that partners are involved, as I said, because I think helping the partnership talk to one another is very key to supporting patients if they are with a partner. And I would definitely encourage you to include partners in all the support groups that perhaps you set up, and try and normalize some of their concerns, try and help them adjust to this new normal. And I think upfront information and giving more information upfront about the consequence of treatment. The patient may not take this all in because they're often, as I said, fearful about their mortality at the time of diagnosis. But by giving that upfront information and being written information as well, the patient can review that and look at that, and that will help them realize that what they're suffering is not unique to them. This is to be expected, and whilst it's not nice, it helps start to normalize things. Clearly, we've talked a bit already about lymphedema, and lymphedema can be a big problem for men who have had groin surgery following their penile cancer. And really, the way to manage lymphedema is as a multidisciplinary approach, but it's all about good skin care, preventing infection, because clearly any time you get an infection in the skin or cellulitis, it will damage the remaining lymphatic channels that they have. So good skin care, preventing infection is important. And then managing swelling is around compression bandaging, garments, elevation. Exercise remains important, so it's key that these patients continue to exercise, but you need to warn them that the lymphedema will be worse immediately after the exercise. But the exercise really does help keep the muscle pump going and helps with the flow of fluid through the remaining lymphatic channels, and massage is another important process as well. When it comes to voiding dysfunction, as I say, this can often lead to social exclusion. The patient avoids situations where they might need to go to the toilet because they're worried about public toilets or worried about not being able to use a urinal, and the questions that may come up about why they've gone into the cubicle. They're worried about the dirtiness of the cubicles, and they're worried about, clearly the spraying and perhaps needing to use a funnel. So the voiding dysfunction has a big impact on our men. So in the UK, we are fortunate that penile cancer is a centralized service, which clearly has lots of pros. It has a few cons, as outlined on this slide. But I think the pros clearly are around our ability to have a specialist MDT, a holistic approach to the patient, and to really have the services, the specialist nurses, the psychological and psychosexual services that our patients need, access to lymphedema services too. Clearly, there are other benefits as outlined there around the advancement of penile preserving surgery, surgical staging of groins, perhaps using sentinel nodes, allow improved survival has been shown with centralization and research and innovation. I know centralization is not available in all countries, but what I would suggest is that groups treating these men, if they're not in a big centralized service, perhaps come together to share some of that expertise, to share that multidisciplinary approach, to allow their men to have access to the services that may not be so readily available, such as the psychological and psychosexual services. Clearly, there are some disadvantages of centralization around travel, the financial burden of the patient of traveling, but clearly we can do quite a bit now online. And I'll show you on one of the next slides that I myself actually travel out to do clinics closer to where my patients are referred in from. So I do lots of outreach clinics to save the patient traveling. So there are ways of overcoming these cons, and there's more on this in the guidelines if you wish to read that. So just an example of my practice, it is very much a multidisciplinary approach. We have access to our to specialist nurses, lymphedema clinics, psychological cancer support teams, and also we work closely with charities in the UK. These are Macmillan and Orchid, who help support our patients. But we also have set up prehabilitation for pre-operative optimization. We have information leaflets that our patients all get. We have patient support groups, some of which are face-to-face, some of which are online. We use a holistic needs assessment. We have an open door policy, so if a patient has a problem, they can return to our clinic the following week. So we have an open door policy to our clinic. Nobody has to wait to see us. We will see whoever needs to be seen in our clinic on a weekly basis, and patients have that open door back to us. But we do go out and do these outreach clinics to save traveling. We also have access to exercise services, services that are set up in the community. So 5K your way, this happens every Saturday. You can run it, you can walk it, and cancer survivors come together. So again, it not only helps with keeping them fit, it also gives them some support because they get to talk to other people who have been through a cancer diagnosis and move more as a similar thing. Clearly, this work is not all mine. There's a lot of people to acknowledge. First of all, my patients. A lot of what I've explained to you, I've learned by talking to my patients, and clearly I'm very grateful for everyone that has shared their experiences with me. My surgical colleagues, Professor Watkin and Sylvia Yan, our specialist nurses, particularly Chris, Millie and Miriam, my psychologist, Sahil Suleiman, and my lymphedema therapist, Mark Pearson, and clearly all the trainees that have been through our units, past and present. So these are the recommendations from the EAU guidelines and ASCO guidelines in terms of quality of life and how to deliver survivorship. And clearly the top there is about being part of an extended multidisciplinary team, as we've been discussing. We need to discuss the psychological impact of penile cancer and its treatments up front and offer the patient psychological support and counselling services. We need to obviously discuss the negative impact of treatments on urinary and sexual function up front so the patient is better prepared for the challenge he may face, and likewise lymphedema. So my take-home messages are: have a multidisciplinary team approach to survivorship, try and normalise the concerns and have active and holistic discussions with patients to address their needs, and empower and listen to your patients and their partners. So I will come out of sharing my screen there and hand over to Rob and John, who are going to talk a bit more about experiences and what patients perhaps say to them when they interact with patients and support patients through the disease. So thank you, Rob and John, for joining me now.
Thanks, Ben. Good evening, everybody. As Darren mentioned and Michelle mentioned in the introduction, my name is John Osborne. I'm a penile cancer survivor. I was diagnosed in 2016 and had a radical circumcision, followed by a sentinel node biopsy and further surgery to take away some other cells that were not looking too good. That happened in a very quick period, really. And I think, like many people, unlike many patients, I didn't know that there was such a thing as penile cancer. Like many other patients, I was misdiagnosed for 5 months within general practice before getting a diagnosis of penile cancer. I think it's an excellent presentation that Ben has given. And I know he knows I'll say this, is that the reality is that is the gold standard of care that we would like to see provided for men with penile cancer. And it is the standard that is being offered by some centres within the UK. We know that. And we're very grateful for the work they do. The reality, though, I think, even with a centralised system like that in the UK, is that the reality is that the experience for many men with penile cancer is very different. The emphasis is on the plumbing. It's on the first bit, it's about getting rid of the cancer, which is absolutely essential. I'm not saying it shouldn't be at all. But I think from then, things tend to be very different. In my personal experience, I did not see a specialist nurse. I was not offered any form of counselling, any form of psychosexual counselling, any sort of support post-surgery at all, really. And I don't get me wrong, I don't expect my surgeon to be my counsellor. What I do want, or what I did seek, was access to understand what was happening to me. And I think one of the things that came out from Ben's presentation, this whole notion of being questioned as a man. One of the things that I think the easy part, as I say, is the surgery. And you're suddenly given this all clear. Yes, you're cancer-free, we'll monitor you, blah, blah, blah. And there's this sense of euphoria. Yes, that's it, brilliant. But actually, in reality, that for many men is where the story really starts, because you're left with this whole range of feelings, emotions about what is happening to you. And I remember one of the main things for me was I wanted to know how I felt about what I was going through, was what other men felt. Like Ben mentioned, I questioned my sense of who I was as a man. Even though I retained my penis, there was this whole sense of what is the penis in relation to the whole sense of masculinity. And I really wanted to talk to other men. I contacted the centre where I had my surgery, and they were very surprised because, according to them, men don't want to talk. Well, this one did. This one was desperate too, and it was only as a consequence of talking to Rob, who's on your screen now, that I was able to understand and get a sense of dimension to what was happening to me. It was then I began to realise that the experience for many men was not good, both through diagnosis, treatment, and survivorship. And so for the last 8 years now, I've been involved in trying to raise awareness, both within the general public, but also for clinicians, about what, particularly in general practice, what penile cancer is, how it affects people, and what it means. As a member of the guidelines panel, I was amazed when the panel itself decided that they wanted to put survivorship and quality of life right at the beginning of the guidelines, and to emphasize how important that was. And that didn't come from patients saying and lobbying, this is what we must do. That came from the group, who I think have made this major shift in terms of understanding the impact and the importance of survivorship and quality of life. There's no point, absolutely no point, in fixing us if you leave us broken, as a very good friend of mine frequently says. And I think that it's really important, if nothing, no other message goes away from today than that. You know, this holistic approach is so vital. It's really fundamental. I think the other thing that just in terms of the sort of initial comments really is that the whole notion of penile cancer being something that usually happens. We hear a lot of stories from men. We hear their stories about what has happened to them, but we don't have data. We don't have research data, but we also don't have data from men about their experiences, what they've been through. We hear these things, and that is one of the major problems we face as well. And perhaps we'll talk about that a bit later. Thanks. Over to you, Rob.
Yeah, thanks, John. I wanted to sort of maybe focus on what you could call maybe a non-clinical intervention to try and help meet some of these unmet needs. And I think you can pretty much summarize the problems that men experience as being isolation, the psychological impact, and the physical impact and practicalities. And I think isolation is pretty underestimated, because penile cancer is rare. Unlike prostate cancer, where there will be people you can talk to understand about prostate cancer, may know somebody who's been through it. With penile cancer, nobody knows about it, let alone the treatment options and the long-term side effects. I think the second, the psychological, that will impact on the psychological burden, because if you're so isolated with nobody who understands, it's just going to add to the problems you already have in trying to come to terms with the trauma of your surgical treatment, which is going to be invasive, and the new way that you must function in everyday life. So from the point of view of urinary problems and sexual function, these are all things that are going to have a huge impact. And then the third, the physical practicalities, again, we're looking at potential sexual dysfunction, trying to adjust to a new way of doing things from a urinary point of view. Many men may have some incontinence, urinary spraying. That requires a complete rethink of how they go to the toilet, how they access the toilet, and what they can do to help them build to some degree some normality. And even if care is centralized, I really don't think that it's going to be available when men need it. So there will come a point that even with centralization, healthcare professionals or clinicians may not be available, and they may not know themselves exactly what's right. So one of the things that I'm always quite keen to look at and maybe explore is the use of peer support. And I know, John, you've made use of peer support. Now, unfortunately, with penile cancer, peer support is very rare. In the UK, there are a few physically meeting groups, and Orchid are trying to facilitate more virtual style meetings. And if anybody wants to find out about those meetings and things in the UK, please email me or phone our Orchid Male Cancer Helpline. But there is a very big online support group, and I think we can probably post the address after this video to anybody who's interested, which I think shows exactly how effective this sort of non-clinical intervention can be. Now, this group is a global group. It's a closed Facebook group. It's been around for many years now, and there are around about 600 people, more or less, on there. And this is made up of patients, it's made up of partners, and it's made up of family members, all who can post on that group. And from the point of view of everything I've just been discussing, it can create a tremendous improvement. So if you're a man with penile cancer and you post on there about your experience, you will have 5 or 6 men reply back to you saying that they've been in a similar situation, offering you support. That means you are no longer alone. The isolation is reduced. There are people out there who have been through this. That can be a huge changing moment. Again, just knowing somebody is out there, they've got through their disease, they're on the other side, they have adapted. Again, that can be a huge benefit to the psychology of what you're feeling. And one thing that I have noticed with this group recently is that there are men on there who have had counselling, which is something men will tend to shy away from, who have had a good experience and are trying to get other men to undergo that experience, probably in a much more effective way than a clinician could. And I think from the physical practicality, there is a wealth of information about there. We're not just talking about men who are going or have been through it. We're talking about partners and carers who've had to adapt and come up with innovations and ways of helping their partner get through, from the urinary side of things to managing lymphedema and other problems. And I think that is a huge improvement or way of a non-clinical intervention around penile cancer. The only sort of caveat is that obviously with support groups, there are people in good places and bad places, and that can be hard to take initially, but there is a huge amount of experience from all those people on that group which will have an extremely beneficial effect on quality of life. And I know, John, I was just going to ask you about your experience of that, because I know you had the group.
Yeah, thanks, Rob. I would encourage anybody to join any support group that is available. I think when we talk about rare diseases, the patient experience is often very lonely. Rare equals alone in my book. You don't get to meet other people, you don't get to see them, you don't get to, and any chance to do that, I think, is highly beneficial. The group is remarkable. There's also a messenger group which is for men only who've had penile cancer, which is also very useful. And again, I'd encourage people to look into that too. I think the more support groups we can get, the better. Whether that's online or face to face, it's vital.
Oh, sorry. Carry on, Rob.
No, I was going to say the other thing that I think is vital from the patient perspective is to actually gather the proms that we need. And I know John has created a patient-led survey around this, which has just been launched. And I would encourage anybody who knows anybody who's been affected by penile cancer to make them aware of it.
Thanks, Rob. I think, yeah, I mean, I think, again, I would just say that I've never been asked to fill in a PROMS form ever. Until recently, I've never seen one. And the whole sort of notion of holistic assessment doesn't happen in a lot of places, and we should encourage this. We should encourage the holistic approach that Ben outlined as the best way forward. Just wondering if we've got any questions.
Not at the moment, actually, but I will invite, but I didn't actually say for people to send in any questions they might have. So we'll give people a few minutes to do that.
Thanks, Ben. Thanks, Dan. So, Darren.
Yeah, well, thank you, John and Rob, for sharing your expertise and experience there. And I think all these facets around holistic care, PROMs, peer support, really, as a clinician, adjusting the information you give in your approach, to the individual patient in front of you. And you can only understand that if you have that information, from the patient, and you only get that through a holistic approach. So really important to follow all those facets, and important that partners are included as well, because they're suffering and often can be really supportive and helpful for the patient if they're given the right support themselves. So I'm not sure if any questions have come through yet.
No, we don't have any questions, but I would like to say, I guess at this point, that if anyone's watching this back on YouTube or on our GoToWebinar channel, yeah, if you do have a question, if you're watching on YouTube, you can always post your comments there. Otherwise, you'll have my email address from in the descriptions as well, so you can also email me any questions. I can pass them on as a later date to the presenters.
Thanks, Darren. I think Rob mentioned the survey that I'm running at the moment, which Ben has been involved with as well. There is a short video which Rob has put together to help explain about the project, and this whole sort of notion that we need more data. We need to understand what is really happening out there for men. and that video will be played shortly at the end of this session if there are no further questions.
Yeah, so we don't have any questions at the moment. So if you say anything else and then play the video as an outro, is that what you'd like to do?
Could I, yeah, I mean, John, could you just give a sort of overview of the sort of questions and that you're asking?
Yes, certainly. The survey came about really after a conversation that the three of us had with a couple of other reps at a meeting in London about 4.5–5 years ago, where it became clear that whilst there were sort of centres of excellence, the experience was not the same across the centralised UK system as we thought. We didn't really know what was happening in each of the centres. We didn't know how many surgeries they were doing, how many people they were seeing, what type of surgeries they were having, levels of lymphedema as a consequence. I live with lymphedema, and I think we'd toyed about this idea of trying to get a snapshot of what was happening in the UK. It was only sort of last year that I thought, well, we can't wait around really. The clinicians are far too busy to do this. We expect them to do far too much. And what I wanted to do was to put out a patient survey that was designed by patients for patients and will be reported on by patients about their experience. We're using in the first instance, we're using the Facebook group that Rob mentioned and the Messenger group to get out a version in English, which went live on yesterday. We're getting responses back to that. We want to try, it's a very ambitious project, and we want to try and get 400 responses from men across the world. We're working with the patient office of the AAU and with eUROGEN to help promote the survey. And when we get the first responses back, we are hoping to get the survey translated into the European languages so that we can then get that out across the world to other communities. I'm particularly interested in Spanish and Portuguese because we know that in Brazil there is a very, very high incidence, which was reported on last week in an article by the BBC. It's horrendous, something like 6,500 amputations in the last 10 years. It's remarkable. So we want to try and get a picture of what's happening, and it's both through levels of awareness. Did people know there was such a thing? How were they treated in the pre-diagnosis? What happened at the point of diagnosis? What treatment they were offered? Were they offered any post-treatment support? And then there are quality of life issues, looking at issues like sexual functioning, like all the things that have been mentioned this evening in terms of voiding, in terms of the social pressures, the stigma, and how people feel about their experience. I think it's really vital, and I would love people to encourage to share this with their patients. It is available on the Facebook group. There is a link available if you'd like to contact myself. I can make that available to you, and Rob too. We want to just pool all that information as much as possible to get a picture of what is really happening out there and get some data. So thank you.
Okay. Sorry, I was just going to say, if Rob, John, Ben, if there's anything you want to, links, information you want to provide to the registrants, not just the attendees today, if you can send it to me, we can include it in the email we send out to all of the registrants with the video links as well. And we'll put it on. We can also put it into the YouTube description as well, so people will have it there if they're watching this back later.
Thanks, Darren. That's brilliant.
Okay, so anything you guys want to say to finish off, and then I'll play the video if that's okay.
No, just thanks everybody for listening.
Yeah, I'd just like to thank Rob and John for joining me this evening and giving their experience and expertise, and I hope that you found this session useful, and I hope that it makes you think about survivorship with slightly different lenses, and that really it's about a holistic approach rather than just purely a clinical one. But thank you all for attending, and I hope you found it useful.
Yeah, thank you everyone. So yeah, thanks everybody. Really thank you to the presenters for doing this evening. And yes, thank you to, as always, to our attendees. Please, we're having a summer break now from our webinar program, and we'll restart in September. But please do keep an eye on our website for further details. As I said, we'll send the link out tomorrow with more information for the recordings and anything else, useful links as well on this topic. Okay, so thank you everybody. I hope you all have a good evening. So I'm going to play the video now, and then I'll finish the webinar after that. Thank you. Just 1 second, it'll take a second to start, so apologies.